Welcome to this conference. I wanted to thank Catholic Charities for organizing this conference and all the co-sponsors as well. I'm going to start with this very melodramatic statement. Alzheimer's disease is a public health crisis. I think that's really true. We know, all of us in this room know, it's a very common problem. Over 7 million Americans are living with the disease. It's the 6th leading cause of death across all ages, and 1 in 3 seniors will die with some form of dementia. What about Hawaii? We have over 31,000 people in Hawaii who are living with dementia. There are 62,000 caregivers providing over 100 million hours of unpaid care in Hawaii. And we also know this about caregiving. It is a health risk. We know that caregivers are more likely to have chronic health conditions, more likely to have depression, and be in poor physical health. So all of you here in this room, first of all, please give yourself a round of applause for all the work you're doing with your caregiving. It is the hardest job in the world. And I also will really implore you, please take care of yourselves too, because we really need that. Your loved one needs you to be in good health so that you can care for them as well. This statistic is very interesting. If you look at causes of death and the changes in cause of death between 2000 and 2022, so over that 22 years health span, basically breast cancer, prostate cancer, heart disease, and stroke remained more or less stable. Those are the 4 left ones. HIV actually dropped as a cause of death. But look at dementia. It went up by 142%. Again, our aging population is part of this reason. We have people living longer, so they're living to be in the risk group for developing dementia. But you can see this is becoming a bigger and bigger problem as time goes on. So I'm going to start with some introduction about what dementia is. And before I do that, I want to tell you what it's not. So these are some common myths about dementia. One is memory loss is the same as senility, and it's an inevitable part of getting older. I actually looked up the definition in the dictionary of senile because I used to see that even in medical charts. They don't have dementia, they're just senile. I mean, what are they talking about? Senile means old. If you're saying old equals dementia, you're saying every older person is going to get dementia. And we all know that's not true at all. My mom passed away about 6 months ago. She was 93 years old. Her mind was sharper than mine. Seriously. She was really, really fit. I mean, physically she wasn't. She was very frail. But mentally, she was really, really sharp. And all of us know people like that in their 80s, 90s, even centenarians who are really mentally sharp. So while it is common, more common for people who are in older ages to develop dementia, it's certainly not inevitable. The other myth is that nothing can be done. I've even heard some physicians say that. They've said, there's no cure, so why do you bother to even look? Well, I would argue they're right, there is no cure, but there are treatments, and there are lots of other things we can do, including support for the patient and for the family. The other myth is that most people don't want to know if they have dementia. And again, studies have found this is not true. When they've asked older people, if you did develop dementia, would you want to know? The vast majority of people say yes. I would want to know, I would want to plan. So all of these misconceptions, unfortunately, contribute to under-recognition of dementia. So what are the facts? First of all, it is not normal aging. It's really a constellation of several types of diseases. The other fact is that it's common, underdiagnosed, very expensive, and it is a fatal disease. Again, even physicians think you can't die of dementia. Well, you can. You definitely can. And then the other fact is that people who are living with dementia should have a thorough evaluation by a physician who's experienced with this condition. Sometimes that can be very hard to find. The people who specialize in this are usually geriatrics and neurology. There's a shortage of geriatricians in the state of Hawaii. There's a shortage of neurologists in the state of Hawaii, particularly when you go out to neighbor islands. For example, Maui has 0 geriatricians. Kauai has a few, has 3. Big Island has a handful, but not too many, actually. They're in very specialized places, so the general population doesn't have access. Even on Oahu, the wait list to see a geriatrician is extremely long. Neurology, similarly, I think it's a little bit better on the neighbor islands, but still there is a shortage and a long wait list as well. So what is dementia? First of all, it's acquired deficits. These are people who were intellectually normal, were not born with congenital intellectual difficulties, and then developed a change in their intellectual status. We do see deficits in memory, but not only memory. We also have to have at least one other cognitive domain affected. On the next slide, I'll show you what I mean by that. It has to be bad enough that it's affecting the person's social functioning with their family and friends, or if they're still working, it's affecting their job performance. So if it's milder than that, it doesn't fall into dementia. And then we need to have an absence of delirium. Delirium is an acute confusional state that's usually seen in the hospital. I don't know if you've ever visited an older person in the hospital and you've gone, wow, they're really confused. This is not their normal state. And then a few days later, they might be back to normal, or they might go up and down. That's a delirium, and that can be caused by any acute illness. So in the presence of an acute illness like that and a delirium, you really cannot make a diagnosis of dementia. You have to wait until the delirium clears. The other thing is you have to have an absence of major psychiatric conditions like depression. So if somebody's in the throes of a major depression, that first needs to be treated before we can decide, does this patient also have a dementia? There's this condition called mild cognitive impairment, or MCI. This is where we see sometimes a subjective complaint. It can be with the patient. More often, it's not. More often, it's a proxy informant, a family member, or a friend. The patient may or may not even realize that they have a problem. You see deficits in testing. So when you do memory testing, cognitive testing, at least one domain has to be affected. It could be memory, could be language, attention, executive function, which is planning tasks, or could be visuospatial type of activities. But even though the testing is abnormal, they have normal functioning socially, and if they're working, they can still function at their job. Because remember, if it's affecting their social or occupational functioning, they have dementia. So these are people who can still function well, but on testing are showing some deficits. It's sort of a pre-dementia syndrome, actually. It's a precursor. And we know that about half of these people within 5 years will have a diagnosis of dementia. The conversion rate is something like 12 to 15% per year. Why do half convert to dementia and why do the other half not? Wouldn't it be wonderful to know if we could keep people frozen at this stage where they're still functional, they still have quality of life? Wouldn't that be wonderful? We don't know. Nobody knows why. There's a lot of research being done, though, because people realize if we can prevent MCI from converting to dementia, that would save a lot of misery and a lot of cost as well. So how common is it? Depending on the study, I see different statistics, but I would say about 13% in the age group of 65 and older. When you get to the 85 and older, it's about 50%. So it certainly does become much more common with aging. We see this geometric increase in the prevalence of disease. After the age of 60, the prevalence doubles every 5 years. So I actually have a graph to show that. Let me see if I can use the mouse. So this axis here is age, and it's in 5-year increments, starting with 60 and ending here with 85. And on this axis, here's the percent. The people in red, that's this one, the higher one, represent both dementia and MCI, whereas the blue line represents only dementia. So obviously with MCI, it's a little bit higher. So you can see it's not a straight line. It's geometric. It curves because it's doubling every 5 years. And by the time you hit 85, you see it's about 1/3 of people will have a frank dementia. And if you add the MCIs, it's almost half. The reason why we see this dramatic increase like this is because it's a very long disease. People live with this condition for many, many years, sometimes even for decades. It's a major cause of disability in older people, and it's really the primary reason for being put in an institution, nursing home, care home. It's really the main reason. In the state of Hawaii, if we look at nursing homes for long-term care, not rehab, lots of people go in for rehab. But if you're looking at people who are there for long-term care, they're going to be there for the rest of their lives. About 75 to 80% are there because of the diagnosis of dementia. Look at that cost. Over $380 billion annually for care, and more than that for caregiving and lost productivity. I personally know so many people who've taken early retirement or who've basically been taken an easier job. Maybe they're overqualified for that job because they want to have time for their family, for their caregiving. So, and then even lost time because you need to take time off maybe to take your family member to doctor's appointments or for other emergencies. It is a very expensive disease. And again, families are bearing the majority of this cost. So next I'll talk a little bit about symptoms and about diagnosis. The common symptoms, of course, memory loss is sort of the high point. We see short-term memory loss first, and then later even long-term memory loss. I think this is one of the reasons that people can get fooled, and this is why it can be under-recognized. So I've again had patients, families tell me, Mom's memory is great. She remembers things from 40 years ago. That's probably true, but she cannot remember what she had for breakfast half an hour ago. So I think that's why people think, oh, memory is not bad, because they're looking at the long-term memory. But it's really the short-term memory that goes first. Disorientation is common to date, to place. Now, I don't mean disorientation, for example, when you're traveling. Getting lost when traveling is not unusual. God knows my family and I do that all the time. Even with Google Maps, we sometimes get lost. I'm talking about getting lost coming home from the grocery store to the home you've lived in for the last 20 years. Familiar places even, you can get lost. Difficulty with naming, difficulty with understanding. Sometimes even having a conversation with an older person with dementia can be very difficult. A lot of times patients will have lack of insight, which means the most common answer when I ask the patient, how's your memory, Mr. Suzuki? The most common answer is, my memory is great, doc, because they don't even realize that they have a problem. They lose that insight. Depression is also very common, particularly in the early stages. Behavior problems, personality change, wandering, all of these are important, and I know that the rest of the conference will be dealing a lot with these behaviors. And then at end stages, patients become socially inappropriate and show very poor judgment as well. This is a complicated slide, but I just wanted to show you that different parts of the brain do different things. And sometimes knowing where the lesion is. So for example, if somebody has a stroke, if the stroke is in, it's not even necessarily the size of the stroke, it's where the stroke is that might make a difference whether somebody has behavioral problems or not. Size does matter, but it's also the location of the stroke. So for example, the front of the brain, right over here, the frontal lobes, very much controls personality, behavior, social skills, even planning. The temporal lobe on the side is memory and mood. The parietal lobe is spatial awareness. And the occipital lobe in the back is the visuospatial type of processing. So again, the different parts of the brain can cause different types of problems for the patient. So for diagnosis, history is really important. Of course, we do ask the patient about history, but honestly, the most important history comes from the family, the persons living with that patient or who know them the best. Because the patient can give you any kind of information. You really need to corroborate with the family, is that really true? Because the patient might be telling you something that they think is true, but is not. The physical exam, memory testing. Blood tests are important to rule out other conditions that can be treatable. Similarly, we do a CT scan or an MRI scan of the brain, again, to make sure that we're not missing certain conditions. Now we finally do have some tests that are diagnostic for Alzheimer's disease. So the amyloid PET scan is basically the gold standard right now for making a diagnosis for Alzheimer's disease in particular. Hawaii does not yet have an amyloid PET scanner. So currently, if you want to get one, you have to go to the mainland to get it. But Queens is in the process of trying to get it. I believe HPH is also. I'll let Dr. Chung, he's this next speaker, I'll let him talk to you about when we're hoping that this fall it will come in, but we're not really sure. And then sometimes additional tests can be done as well. So for dementia, we always deal with the ABCs, activities of daily living. As the dementia progresses, slowly people are unable to do more and more things need to be done for people like yourselves, the caregivers. Behavior can be very, very distressing. And again, you really need to make sure that the physicians know about these behaviors so that they can help you. The C's are the two C's. One is cognition. We know that that's going to be steadily declining, but also the caregiver. When I used to see outpatients, I always took the caregiver aside separately to ask, how are you doing? Not in front of the patient, because in front of the patient, the caregiver will say, I'm doing fine. I really want to know how the caregiver is doing, because we need, as physicians, we need to not only take care of the patient, but also of the caregivers. Disease progression, unfortunately, right now is still inevitable. We do not have a cure. And education, I think, is key. Educating patients in the early stages if they're still able to understand, and definitely educating caregivers, all the caregivers. At that first diagnosis of dementia, a family meeting is really important. This is something that's going to be lasting for many years. The whole family needs to understand. The patient is not doing these things on purpose. This is a disease process. So the family meeting can really help with that. Next, I'll talk about the subtypes of dementia. So I want to really stress this one slide. Not all dementias are Alzheimer's disease. It's the most common type. So if you look at the box on the left here, depending on the studies, again, 60 to 80% of dementias are Alzheimer's disease. But there are many others. There's vascular dementia, Lewy body, frontotemporal, and many, many others. And some of these are actually reversible or treatable. So again, it's very important that we try to pinpoint exactly what's going on in the brain. So if you look at white populations, this pie chart here kind of gives you the approximate split of the types of dementias. So this blue big wedge is Alzheimer's disease. Again, about, say, 2/3, 3/4 of dementia is that. Then we have vascular dementia. Vascular dementia is related to strokes. And this, again, depending on the study, is about 10 to 20%. Then there's Parkinson's disease and other Parkinsonian syndromes, like Lewy body dementia, and that's a smaller piece of the wedge. And then there's mixed and other dementias as well. I'll give you some information from our local study at Kuakini that shows that some of our Asian populations may have a different mix of the subtypes of dementia than white populations do. So I'll talk a little bit about the 4 most common types of dementia. Again, the most common, of course, is Alzheimer's disease. And the reason people develop this disease, it's not a psychological condition, it's a medical condition. They have deposits of abnormal proteins in the brain. So the 2 major abnormal proteins that we see are beta amyloid, which is laid down in plaques, and neurofibrillary tangles, which are made up of this protein called tau. These abnormal proteins we see in the brain on autopsy. Dr. Alzheimer, the doctor who first discovered Alzheimer's disease in 1906, that was over 120 years ago, he already knew about these abnormal plaques and tangles. The original patient with Alzheimer's disease was a young woman in her middle-aged woman in her early 50s, who had very bad behavioral problems, progressed quickly. When she died, he took her to autopsy, he got her brain, and he already described these plaques and tangles. The symptoms associated with Alzheimer's are many. It's impossible to list them all on one slide, but these are some of the common ones. Repeating questions is a really common symptom that people, and unfortunately, that drives people crazy. It can be very difficult. It takes a lot of patience, but there's no point in arguing with somebody with Alzheimer's, saying, you just asked me that 20 times, because it'll just make them more agitated. So to just keep answering the question or to find other ways to answer the question. Sometimes little clues, because if the person is at home and they're asking, where's the bathroom? And you're like, you've lived in this home for 50 years. You know where the bathroom is. Instead of that, put a picture of the toilet on the bathroom door. Not the best interior decorating, I know, but worth it to not being asked over and over and over again, where is the bathroom? Because those little cues can kind of help. In moderate stages, people can even have trouble recognizing family and friends, which can be very distressing as well, can have very impulsive behavior. And of course, in the end stages, even communication is impossible. Vascular dementia or stroke-related dementia, this is because of blood clots or other things that disrupt blood flow. So little pieces of the brain are actually developing strokes and dying. This type of dementia may have slightly different symptoms. People can forget current or past events, can misplace items. Learning new information can be very difficult for people who've had strokes. Trouble following instructions as well. Showing poor judgment, sometimes hallucinations or delusions can happen. Again, depending on the location of the stroke, the symptoms can be quite different as well. Lewy body dementia, again, has a different abnormal protein that's laid down. This is abnormal deposits of something called alpha-synuclein, which forms little blobs called Lewy bodies. And this affects the way the brain can send chemical messengers between cells. So these patients, in addition to having cognitive or memory problems, will also have movement problems. They might have muscle rigidity. They might be really slow in their movement. They might have coordination problems, sleep problems. Visual hallucinations are common in people who have Lewy body dementia. Again, can be very distressing to the patient and can be very distressing to family members as well to kind of watch this. The other thing about Lewy body dementia that's quite common is major ups and downs. Now, even Alzheimer's disease has ups and downs, right? You have good days, you have bad days, kind of steadily going down, but good days and bad days. The good days and bad days have a much wider swing with Lewy body dementia, much more ups and downs very quickly. Frontotemporal dementia is something that actually we as geriatricians don't see as much. I think the neurologists see more of the frontotemporal dementias. This is because they tend to happen at earlier ages. They tend to happen a little younger, for example, than Alzheimer's or the other dementias do. Again, there's a different type of abnormal protein, tau and TDP43, which are deposited within certain parts of the brain. These patients probably have the most behavioral problems, the worst ones. Major problems with impulsivity and impulse control, or the opposite, they can be very emotionally flat and have no emotions at all. Can have some movement problems as well, and can have some language and speech problems as well. These often can be very, very distressing behaviors. So next, I'll talk a little bit about the research program at Kuakini Medical Center that I've had the honor to be part of for many decades, the Kuakini Honolulu Heart Program and the Honolulu Asia Aging Study. If you're anyone in the audience, if you're Japanese ancestry and your family is from Hawaii, chances are very high someone in your family at some point was part of this study. They're all gone now. It started in 1965 at Kuakini Medical Center with 8,006 then middle-aged Japanese American men. It was originally a study of heart disease and stroke. From those 8,006 men, 2 are still alive that we know of. Those 2 are 106 years old, both of them. So this cohort has really extreme longevity as well. The Honolulu Asia Aging Study began about 25 years after the start of the Honolulu Heart Program in the same cohort, in the survivors. At that time, they were older. They were 71 to 93 years of age. And people at the NIH who had been running this study all this time realized, wow, we have data on heart disease, stroke, and risk factors for 25 years, and now this cohort is older in the ages that does develop dementia. They added in dementia outcomes, which was a very, very smart thing to do. This is one of the few studies in the world that has midlife risk factors and late life outcomes. Most studies of dementia don't start in middle age, they start in old age. Because if you start in your 40s looking for dementia, you're going to be waiting a very, very long time to find them, right? So this was a very unique opportunity, and I'm really glad that the NIH jumped at it. The purpose shifted. Instead of heart disease and stroke, they were still going to look at that, but also to look at cognitive function, dementia, disability, and other diseases of aging. Last year, by the way, was the 60th anniversary of the Honolulu Heart Program, and we did have a celebration for that. With the men were gone, but with their sons and daughters, the offspring. So these are some of the results. When we look at prevalence rates of dementia, again, I'm going to try and orient you to this slide. On this axis are the age groups. So this is the youngest age group, 71 to 74. This is the oldest, 85 and older. And on this axis is the percent, the rates with dementia. The blue bars are those with dementia that met our research criteria. And the red includes MCI, or mild cognitive impairment. So these are people who are still functional, but are testing poorly on their cognitive tests. And as you can remember that curved line I showed you, this is again a very curved line. And the numbers are very similar to the national numbers. About 1/3 who have dementia and almost half who, when you add in the MCIs. So this reiterated that in this Japanese population of men here in Hawaii, the rates of dementia are very similar to in white populations. But the next slide shows how we were different. So when we looked at the subtypes of dementia, if you remember that pie chart that I showed, where Alzheimer's disease was a huge chunk of the pie and vascular or stroke dementia was a tiny little sliver, right? 10 to 20%. Here we have, again, the same age groups, and we have blue is the Alzheimer component, and red is the vascular or stroke component. And as you can see in this youngest age group, actually, vascular dementia was more common than Alzheimer's disease. Now, as we get older, Alzheimer's overtook and became number one, but still it's nowhere near that 60 to 80% Alzheimer's and 10 to 20% vascular, right? It's much more equal. And this is similar to studies done out of China, Japan, and Korea, where in Asian populations, vascular dementia has more of an importance than it does in white populations. The other thing that we found that was very different, in many of the mainland studies in white populations, their vascular dementia is by large strokes. So you have a history of strokes. You get a stroke, your cognitive function drops. Then it plateaus, you have another stroke, it drops. You see this sort of stepwise decline. In our men, we didn't see that. Many of these strokes were tiny strokes. Many of the strokes were asymptomatic strokes, subclinical strokes. When we asked the men or even their families, did he ever have a stroke? The answer was no. When we did a brain scan, we found, oh, there were 3 old strokes, subclinical tiny strokes, which can creep up on you. You don't even realize you're having a problem. So I'm realizing my time is getting short. Early detection is really important. Why do I think that? One is treatment of reversible causes. The treatment is more effective if it's early in the disease. The second is treatment of underlying conditions. If somebody is going to the doctor for high blood pressure, for diabetes, for whatever, the doctor is giving him all these instructions. I want you to do this for exercise, for diet, here are your medications. The patient's smiling and nodding and not remembering anything. How are they going to listen to what the doctor said? How are they going to follow that? So the treatment of those underlying conditions means the caregiver needs to be in with them. That means we need to know they have dementia. We need to reduce ineffective and expensive crisis care. We should not find out the first time that the patient has dementia when they're in the ER or when they just had a car accident or something really bad happened. Patient and family education, advanced healthcare directives are important, financial planning. We need to do that early in the disease. I have a whole slide on safety that I'll show you later. Connecting to community services. And then Dr. Chung after me will be talking about the new treatments. They're only effective in very early disease. Some of the barriers, cognitive impairment is thought to be normal aging. What do you expect? They're 85 years old. Well, it depends. If they're 85 and they never cooked, that's not a change. But if they were 85 and they were a really good cook and now they have trouble making instant ramen, that's a problem, right? So again, you're looking at change in functioning. Family denial because the long-term memory is normal. Patient doesn't remember and the patient still has social skills. So when they walk into the doctor's office, they look normal, again, early in disease, they look normal, they speak normally. If the doctor doesn't check, they're never going to know. Some doctors are hesitant to assign the diagnosis because they feel like it's a social stigma, but again, there's so many benefits, I think that outweighs that risk. Doctors are busy. I don't think that's a good excuse. This is care that people need. Some doctors lack the conviction that benefits outweigh the burdens. Again, with the new treatments being available, with all the supports we can give, I don't think that's an excuse. Finding a specialist is difficult. And again, the no cure available, I admit, we don't have a cure yet, but hopefully we will have in my lifetime. So when we looked again back at the Kuakini study, we looked at caregiver recognition of memory problems. This group was people who had no problems. This was people who had MCI by our research criteria, and these were people who met research criteria for dementia. When we asked the caregivers, does Mr. X have a problem with his memory or thinking? I want you to focus on the red. 20% of those who had dementia, their caregivers said no problem. Among the MCI, half. Even caregivers who living with the patient may miss this diagnosis. This was even more alarming. We asked, has he ever been referred for memory problems? Again, with those with dementia, more than 60% had never been referred for memory evaluation. Among the MCI, less than 5% had been referred. This is something, if you don't look for it, you will not find it. We need to educate our professionals to look for it so that we can recognize it early. This was a study done by one of my fellows who's now a professor at UCSF. He looked at a primary care practice in Hawaii, and he looked to see how many of those people had undiagnosed dementia. Among the whole group he examined, it was 2/3 had undiagnosed dementia. Among the mild, 90% were missed. Among moderate, half were missed. Okay, none of the severe dementias were missed. Should we be proud of that? Even a child can diagnose severe dementia, right? Again, not something that we should be seeing. I think I'm going to skip over the risk factors because it's going to take too much time, but I will show you some data about things that can be helpful for the brain, physical activity and social activity. When we looked at our Kuakini study, we looked at just walking and is it preventive of dementia down the road? So on this axis here, we have distance walked. These people walk the most. They walk more than 2 miles a day. These people walk the least, less than a quarter mile a day. And we look to see, does this predict new dementia developing over the next 8 years? And look what we found. This is our reference group. It got higher and higher and higher the less you walked. In the people who walked the least, it was almost double. Similarly, when we looked at social engagement, those who had high social engagement had the lowest risk of developing new dementia, and it got higher and higher and higher with less social engagement. In this group, it was more than double the risk. So this is what's led our study, and others like ours have led CDC, Alzheimer's Association to create the Healthy Brain Initiative. You can actually Google that and find it on the website, which talks about things that we should be doing for the whole population, not just for people who have memory problems. The whole population, trying to keep them more physically engaged, more socially engaged, doing more activities. For safety, medications are a big issue, either not taking your medications, forgetting to take them, or forgetting you took them and taking them over and over again and ending up with an accident overdose. Over-the-counter medications, some of them can be really dangerous for patients with Alzheimer's disease. So it's really important, don't just assume because it's over-the-counter it's safe. Make sure your doctor knows before you give it. For wandering, a medical alert bracelet is really important. The Alzheimer's Association was instrumental in having the silver alert bill passed, which means the minute somebody goes missing, the search can start. Leaving the stove on can cause fires. Leaving the water running can cause damage. Driving, that's a lecture in itself, driving with dementia. These patients are at risk for elder abuse and neglect. One of my faculty did a really cool paper on Hawaii Medical Journal many years ago, looking at excessive sweepstakes participation and some people who had lost large amounts of money, even their property, because they had been basically scammed and they hadn't been diagnosed with dementia, unfortunately, so nobody was watching. So summary, early diagnosis is key. Treat the cause, treat complications. We really need an interdisciplinary team for these patients, not just physicians, nurses, social workers, dietitians, rehab, etc. These patients need regular medical appointments in a safe, stable environment, lots of family education, lots of caregiver support, legal planning, and then community resources. Alzheimer's Association, Executive Office on Aging, Catholic Charities, many other organizations out there. Our goals of care are really to improve quality of life, not just to keep people alive longer, but to improve quality of life. Keep them as independent as possible for as long as possible. Avoiding social isolation is important, and then care for the caregiver always. Quick shout out to the Alzheimer's Association. I'm so glad that they're here today, that they have a table outside. They're a wonderful resource. We partner with them all the time to give educational talks. And I'm going to stop here and I give it up to Dr. Chun.